because it's giving you the specificity of that cervical area. No, I got it.
Hey, where's the president of the excavator club?
Until 6:45 today.
I have class at 1:55, but I'll be there for
So we want to come up there and hear what his respective says.
Okay, because I remember.
We have a tendency one way or the other. But I can say what I would do. And here you're talking to two guys that have sat in my class, in my OCT class, and what are they into? Now they're into the AO.
Okay.
But like Kai, he'll go back to Germany.
A lot of emphasis on that down here in Sources. I want you all to work on that. Psychologically, I'm feeling out. That makes it, each of them got one patient or somebody's pelvic. We've got theirs as well, so we get.
I'll talk to Dr. Swain. One of the other classes when he's been in town. But this guy's back here. He does seminars here at school with the extracurricular classes. And he's practiced in Atlanta for, oh goodness, probably graduated from here back in 1949. And what he's going to present today will be case studies, case histories, and things like that. And feel free to talk to this guy. Here's a fellow that studied under BJ, under Grostic, and so on, that he's been through the whole bit. I met him back in 1960, and he was flying high at that time, and he's still flying high. Big, busy office in Atlanta, and he's presenting a lot of material and developing a lot of things as far as in the chiropractic realm. So he's right on the front line as far as chiropractic is concerned in our world. So, and that's Dr. Roy Sweat.
All right, I want to thank Palmer College and Dr. Hagen for having me out. I am Roy Sweat. We practice in Atlanta, Georgia. We graduated in 1949. We opened our office in 1950 in Atlanta, Georgia, and have been there ever since. In 1952, I got interested in Dr. John F. Grostic's Atlas program. He took x-rays before he adjusted you, and then he took them immediately afterwards. BJ had us, we would x-ray everyone before we adjusted them, but we did not x-ray immediately that same day as soon as you adjusted them. Dr. Grostic studied under BJ in the 30s, and in 1946 he opened he started his seminars in 46. He said that if the x-rays show the misalignments, the subluxations, and then you do your thing, then you should re-x-ray and see if it brought them back to a normal position, a straight position, or whatever. So in 52, I got interested in his program and went up, studied with him, and in the late 50s, we had to send x-rays to him for him to grade and then to judge. So in the late 50s, at that time, our x-rays were the best x-rays in his seminars, and he asked me to help teach his program in the late 50s. So then we taught hand adjusting programs with him until 1964, and he died in 64. We then moved him down to Atlanta. We were doing all hand adjusting at that time. Then we formed an orthosphinology program which was teaching hand adjusting. And then in 1980, we designed the Atlas Orthogonal percussion instruments. 1970, in 80, we then formed the Atlas Orthogonal programs and have done them ever since then. So literally, BJ spent his life studying the Atlas. Nobody wrote more books. Nobody studied the spine more than BJ Palmer. And at the end of his life, he ended up saying the Atlas is the most important vertebrae in the spine and in chiropractic. And when I was in school, he had his hole-in-one program where if you adjusted anything but an Atlas, you were sinning. So I don't quite accept that. I think you can be hurting in the thoracics and lumbars, and you ought to do something in those areas. But at the same time, Grostic then spent his life studying, improving. Grostic began to x-ray immediately afterwards. Grostic began to draw lines on the x-ray before and after. And so then you had his generation. And now since 52, we've done nothing but adjust an atlas. So you're getting about 3 generations of how to adjust an atlas. We still don't have all the facts figured out, but we still got 3 generations of how it should be done. So we then change. My only position, we say all of our work, BJ discovered the atlas. He was the first one to x-ray it, 1911 or so. So then Grostic added to it. And then our generation, if we take any credit, is that we designed adjusting instruments that would adjust the atlas, in my opinion, as good or better than hand adjusting. We do say in the Atlas Orthogonal program, there's more than one way to adjust an atlas. We don't say ours is the only way, and you're crazy if you don't use our system. We adjusted by hand for about 20 years. So can I say you can't adjust the atlas by hand? No, I did. Now we've adjusted the atlas with an instrument for about 25 years, so I certainly say you can adjust the atlas with it. But at the same time, we say you pick out the way you want to adjust it, and then do it. Or as we say, be yourself, figure out how you want to adjust it, and do it. But I think all chiropractors want to do something to the atlas. You can't believe that they almost won't let you get in and out of that office unless they do something to the atlas. And now the question then is, what do you do, what do you base it on, and how do you know what you did? So consequently, we say you should take x-rays before, adjust the patient, take x-rays afterwards. And it's complicated. It's not simple. X-rays have built-in problems. X-ray has distortions. So now it's difficult to x-ray a person. Now in the Atlas Orthogonal program, we not only x-ray them once, we x-ray them twice. So the other second set of x-rays has to be placed in the exact same position, have to take the x-ray at the exact same angle that you did before. So it is like double duty. You're taking x-rays twice, then you're comparing one to the other. So you have to have perfect equipment, aligned accurately, have to have head clamps, have to have the whole show. So it's not simple, but it's being done, has been done since 1946. That's like 50 years we've been adjusting pre and post x-rays. So I think it stood the test of time. And in effect, you are getting 3 generations of how to adjust an atlas. Also, we welcome questions. We welcome to discuss anything. And even if we are not on the subject right at that minute, we still will be happy to divert and discuss whatever's on your mind. The human body is a vertical structure. We are made as a vertical structure. So what that means is you are going to look at the horizon level. That most authorities agree, White and Panjaibi, clinical biomechanics of the spine, agree that the head can move on the superior atlas lateral masses about 5 to 7 degrees. So what it amounts to is the head should be vertical, but it can displace or subluxate to the right or left. Now the eyes can adapt up to about 5 degrees or 7, and still I can lean my head over about 5 degrees and still look at the horizon level. Once I go past that, now I begin to distort. So now the thoracics, nature will shift the thoracics and the lumbars over to keep us where we're looking at the horizon. So a lot of thoracic curves, a lot of lumbar curves are compensatory to adapt us to keep us in a vertical position. Now, we can function off-center. It is like a car. You see cars coming down the road, and they look like they're coming sideways. The frame is bent on that car, taking more gas, wearing the tires out, but it can function. So the human body can function in distorted positions, but it's not functioning at its optimal position. Optimal is the head to be vertical. Now, for the head to be vertical, we need the atlas to be level. The atlas should sit level so that the head can sit vertical. Now, if the atlas is tilted, then the head has to tilt, and now we're into our distortions and our displacement. So we want the atlas level. Now, with the atlas level and the head vertical, we need the cervical spine to be vertical. If you have a vertical head and a level atlas, but the cervical spine is displaced, it doesn't have anything to sit on. So we need to figure out how to get the cervical spine back under a vertical head and a level atlas. So what we're saying is that the head should be vertical, the atlas should be level, and the cervical spine. It's a biomechanical principle that chiropractic discovered, but it is how the body is made. Now, due to traumas, jars, licks, jolts, strains, and accidents, all these structures can displace or subluxate. Now, when they're subluxated, we need to know which way the head is. Is it right? Is it left? Is the atlas high? Is the atlas low? Is the cervical spine right or is the cervical spine left? And we do that with x-rays, and then we come in and figure out how to adjust this back around to get the atlas back level and the head vertical and the cervical spine. Now, if you're at a scientific group of doctors and they say, oh, the head and the neck can displace and it can become subluxated, I'll say, okay, I believe that. I said, okay, now what do you do about it? Oh, we adjust it. All right, and then you say, well, how do you know you adjusted it back to a neutral or orthogonal position? Now, if that group of scientists say, oh, well, we don't post x-ray, then I lose interest in that. I say, how do you know what you did? It's like hitting a golf ball and never looking to see where it goes. If it goes that way, this way, too high, too low, you have to change the way you hit that golf ball. So if these distort in different ways or do not come back, I've got to know. We say it's like a nail. If the nail comes out of the wall, you hit the nail in. We had a carpenter building a patio on the back, and he was professional, but he hit the nail, and he'd look at the nail to see if it went in straight. And he'd hit the next nail. He hit one nail and bent it up higher. Now, you can't keep hitting that nail in that old position. When he bent the nail, he then come up and hit from up here and put the nail in. So how this adjusts, if this is tilted and this is high and you do something and make it higher than when it was, we say that that was not a correct adjustment. That's pretty simple to me, that if the atlas is tilted up on an x-ray and you do something and it's tilted more than when you started, now you've taken them farther from vertical, and in my opinion, that's not the correct position. The adjustment should bring them back to vertical or toward vertical. And I don't see how that can be misunderstood. It is very simple, in my opinion, of what we are trying to do. Also, we have the ring. We have the ring of the occiput, the ring of the atlas, and the ring of the axis. Now we have at the base of the skull, and let me say this, the medics have a new program now called the base of the skull. What is chiropractic? It's the base of the skull. What are the occiput, atlas, and axis? And now they're trying to get MRIs, they're trying to get better x-rays of the base of the skull. So we have the ring of the occiput, we have the ring of the atlas, and we have the ring of the axis. So these three rings should line up and be symmetrical. So if the ring of the atlas is off, or the ring of the occiput is off center, here is the foramen magnum. The foramen magnum is here, and when the skull is tilted to the right or to the left, the foramen magnum is tilted. Dr. Goodhart, the gentleman that started the kinesiology program, he followed me on a program to where we presented the Atlas Orthogonal program, and he was real kind. He said, we agree with Dr. Sweat. He said, in the kinesiology program, we're trying to level the occiput. So if we can get all chiropractors trying to do the same thing, then it's a question of who can do it the quickest, the fastest, the best, that lasts the longest with the least amount of risk. But we're trying to level the occiput. Now the same thing is true. Here's the atlas, here's the ring of the atlas. When the atlas is tilted, the ring of the atlas is tilted. So now we need to get this ring level, and then we have the ring of the axis, and when the cervical spine is tilted one way or the other, the ring of the axis is tilted. So we are not just going in to do any type of adjustment. We're not going in just to manipulate. We aren't. We are trying to bring the head, the atlas, cervical spine to an orthogonal position and to bring symmetry in these three rings. So to my way of thinking, that's pretty simple, and I don't see how it can be misunderstood. We have we wrote this article for chiropractic in the 21st century, and we said here that the chiropractic profession should refer within its own field. We need groups of chiropractors that can refer patients to each other. There's 30,000 chiropractors out there. So let's refer. If we say, write the doctors in your area, tell them you do some special work in the Atlas area, and if they have any patients they're having problems with, we would love to work with them. Now, when they send patients to you, they have become the primary doctor, so you then should try to adjust their atlas, and if possible, send them back to the doctor that sent you. And that's the plan. Now, sometimes they won't go back, but you should at least communicate, tell the doctor you try to send them back. Also, if you're having some thoracics or lumbar problems on patients that's not responding, you should refer them to other chiropractors. So this thing of running chiropractors down and fighting each other is a terrible bad thing. We try to help each other. In Atlanta, we got, I don't know how many chiropractors, 2,000 to 3,000 probably, but at the same time, we send patients back and forth. I've got on the video here this one patient that when the doctor adjusted the patient, he got dizzy. So then she calls me. She said she had the patient that got dizzy when she adjusted him. I said, send him over and let me work with his atlas. We adjusted him, and the dizziness cleared up, and then I sent the patient back to that doctor. And I said, you work on the thoracics, work on the lumbars. If he does get dizzy again, send him back over here, and we'll adjust his atlas. And then I told her, I said, don't you adjust his atlas, let me adjust it. And then you would never tell one of those patients that the doctor was adjusting him wrong or inaccurate. One of the patients said, well, you adjusted me on the right side and the other doctor adjusted me on the left. I said, you can adjust the atlas from either side. I didn't say you were supposed to, but you can adjust it. You can adjust it from either side. So consequently, we've got to work with chiropractors. We would never run a Gonstead chiropractor, activator, Cox's table, or anything else down. Let us work with you. Let us work with each other and see if we can get these people well. The same thing's true with the medical profession. In my opinion, here's the health pie. We don't want the whole pie. All we want is our share of the pie. There's 500,000 medical doctors out there, 500,000. We want all of them to be patients of ours, and we want them to send us patients. My wife had a little femoral hernia there. This surgeon, his wife's a patient of mine. He fixed the hernia on her. Okay, I can't fix the hernia. I can't give you glasses. I only adjust the Atlas. So go to where you need. This chiropractor, Dr. Crow, came in to see us. Called me about 5 o'clock in the morning, and I went down. He had a temperature. He was bent over, couldn't touch his abdomen. I told him, I said, you got appendicitis. He said, yeah, but I want my Atlas adjusted. I said, okay, we'll adjust your Atlas, but I'm only giving it about 30 minutes. If the temperature isn't gone and all that pain hadn't disappeared, I'm calling this surgeon of mine. Anyway, we called the surgeon, went down. He said peritonitis had already set in, operated on him. But the surgeon told Dr. Crow, he said, if you have insurance, I'll take what the insurance pays. If you don't have any insurance, won't be any charge. Now, these people are good, nice people. Weren't trying to eliminate them, weren't trying to. So when you get into life-threatening stuff, suddenly you realize that your health is the most important thing in the world. And remember, we are selling health. You're selling health. We say if you can't sell health, I don't know if you can sell used cars or automobiles or nothing else. You've got to convince these people that their health is the most important thing in the world to them, and they want to get well conservative if they can. Now, if they can't, we'll be happy to send you over to wherever you need to go. This is a 21st century article we wrote. Nevertheless, we say that the occipital axial, atlantal axial complex is a diarthrodial. Diarthrodial means freely movable, synovial joints and have no intervertebral disc. So the Atlas area is a diarthrodial, freely movable synovial joint. White and Panjabis says synovial joint's resistance is 0.005. So that means there's almost no resistance to move that vertebrae within its normal range of motion. Now, if you take it as far as it goes and then give a thrust, that's different. But in the Atlas Orthogonal program, we adjust the Atlas within its range of motion. So it doesn't take horrendous forces to move an Atlas. The question is, which way? Is it high? Is it low? Is it anterior? Is it posterior? And adjusting it back to the proper position. It's like a key to the car. A little tiny key starts a big car, and all keys look alike, but your key don't start my car. I've got to know how the Atlas is, which way it's sitting, and then let me try to adjust it back. But we don't need horrendous forces in the occiput atlas area. Now, there are more movement, there's more range of motion in the occiput atlas axis area than any other part of the body. This Basmazian, he's the MD that started the EMGs, and he says that the vertebral column is a great stabilizer and involves mobility. But he says, however, the ligaments, articular facet, spinous process, intervertebral disc affects the movement. Although there's great range of motion in the spine, movement between adjacent vertebrae are quite limited, except the first two cervical vertebrae, the atlas and the axis. So The motion is limited except in the occiput atlas axis area. Now the next great range of motion is in the L4, L5. What happens is the second range of motion in the spine is L5 with L4S1. The greatest problem in the spine is transitional areas, or in the human body. Here we have a head that weighs 12 to 14 pounds, and suddenly we're on to an atlas that weighs 2 ounces. So now we are in a transition from a head to a vertebrae, and that's the biggest transition area in the human body. Now when you go after the atlas, all the vertebrae look similar. I know the shape different, the facets are different, but basically we all have vertebrae until you get to L5. And then at L5, you go to the sacrums and the iliums. So the second greatest transition area is L5 with L4S1. 95% of disc surgery is done at L4, L5, and there's more L5S1 disc surgeries than L5 and 4. So you have the greatest range of motion, greatest movement, greatest transitional area at the base of the skull, and then the second most is L5 with L4S1. Now some chiropractors say, oh, the thoracic T12 is what it's all about. In my opinion, they can have T12. Your ribs keep the vertebrae from moving. All authorities say the least range of motion in the spine is the thoracic area. So where there's motion and transition is where you're going to find the biggest problem. So we would suggest that you get good in either LC1 or either L5, and we certainly would suggest that you do C1. There's an article that we published in today's Chiropractic magazine, and the article with guidelines for pre and post x-rays. Now, what is hard to believe is insurance companies will not pay for post x-rays. Why don't they pay? Let me say, insurance companies came in the back door of the health field. There's been a health field for all these years. Insurance companies came in and said, let us help patients pay the medical bill. Now they've come around and they're in the front door telling doctors what they can charge and what they can do. Some insurances are fair, that's true, but by the vast majorities, the HMOs, the PPOs, they try to eliminate chiropractic to the point they almost try to genocide us. Now, when I graduated in 1950, the AMA tried to genocide chiropractic. I remember Morris Fishbein was president, and he had the front page of the Atlanta paper said, chiropractors are sharks and charlatans and quacks. On the front page of the Atlanta paper. And that's one way we won the AMA fight, is quoting him trying to genocide chiropractic. Now, it's a little difficult to explain to you. Mom and Daddy, they just paved your way through chiropractic school, and you come home and their front page says you're a quack and a charlatan. But same time, the AMA didn't destroy us 50 years ago. And insurance companies aren't going to destroy us now. We come in. We wrote the article here that post x-rays are a standard of chiropractic care for 49 years. We've been doing this. Dr. John F. Grostic in 1946. BJ took the first x-ray in 1911. Dr. John Grostic 1946, and we have done it since 46, and we are not changing a major chiropractic program because of insurance companies. Then we say they're important to document the efficacy of the chiropractic care. So we take pre and post. Here is the kyphosis Here's a kyphosis here. Most of these kyphoses come back around when the atlas is adjusted properly. Dr. Pierce, I talked with him about it. He passed away last year, but he said he could adjust C5 and make the curve come back out, or the reverse curve out, the curve come back around, but he said that doesn't mean the atlas is right. Then we say when the atlas is adjusted properly, these curves usually come out without much of a problem. And so here's some kyphosis. Here they're back to normal. They come back around without too much of a problem. Here is where the head is displaced so far off center. Here's where it comes back. Here's where it's displaced on the horizontal view, and they come back around. Here is some severe curves here. They come back around. So pre and post x-rays are part of our program. And we did mail these. One of our AO doctors said the insurance company refused to pay for post x-rays, so we mailed the insurance company this article, and then they paid for the post. They said they wanted documentation to show that it was part of a chiropractic program. But most of them still won't pay. So that's up to them. And if they want to cut their patients, their clients short, that's up to them. Then we wrote an article on standard of care for the orthogonal chiropractic program. And we say here that it is defining correct subluxation, spinal subluxation. We have different phases here. We have phase 1, which is the acute phase. The patient's in severe pain here, swelling edema. And in these type cases, we say we should see once every day, 1 to 10 days. The patient is in severe pain. You should try to see him the next day and see if he's improved and if he's getting better. And then after the pain lessens up and decreases, then we say this is the subacute stage, and then they should be seen here 2 to 3 months, 3 times a week for a month, twice a week, and then once a week. Then we have chronic cases that come in once a month, and the insurance companies won't pay chronic cases, but that's all right. Then we have supportive care, phase 4. That's the person that hurts themselves. These are the people that do a lot of exercises, a lot of heavy, hard work. They hurt themselves like once a month or every 2 months, and then they come in and they get adjusted. They'll do this 3, 4, 5, 6 times a year. Usually, we only see those patients 2 or 3 times. They come in, they're in acute pain, we adjust them, and then we check them the next day to make sure they're out of pain, and in those cases, we dismiss or tell them to come back when they need to. Phase 5 is our rehabilitation program. I do think the chiropractic clinics of the future will have a big rehabilitation program. We need to show these patients the exercises and how they can strengthen their back and the neck so these subluxations don't reoccur all the time. So then I think rehabilitation is part of chiropractic care. And then we say that you should be, if a general checkup is like the dentist, you should be checked once or twice a year to see if you're in adjustment or what. We do say all children should have a chiropractic examination. We don't say all children need adjusting, but you should examine the children. They say one of the most dangerous trips you'll ever take is a trip through the birth canal. There's a guy standing out there pulling, twisting your head, trying to get you out of there, and it's a very dangerous trip. So the children should be checked, see if they need adjusting. In the Atlas Orthogonal program, we do take 3 cervical x-rays and 2 post x-rays immediately afterwards. Then we do x-ray the thoracics or lumbars, wherever the problem is. And if you're going to x-ray the thoracics or lumbar, you have to have 2 dimensions. One view is not satisfactory, one view in the lumbar. You got to have frontal and sagittal views. If you're going to x-ray those areas, Any patient that is symptomatic in the thoracic or lumbar area, we say you should x-ray that area. He may have cancer, he may have tumors, he may not have any vertigo, it may be collapsed. You've got to x-ray those areas. And then most malpractice insurance companies say no x-rays, no defense. To take someone in and start adjusting them without taking some proper care and proper x-rays is a very dangerous procedure. This is Dr. John Bland. I was on the program with Dr. Bland. He is one of the foremost authorities on the spine, and he says here that the spine should be treated as a whole spine. He says we have divided it into the cervical, thoracic, and lumbar, and he says this is a mistake, that the spine acts as a whole unit. So then he says here, sometimes the lumbar spine will relieve, treating the lumbars will relieve the cervical, and sometimes treating the cervical spine will relieve the lumbar. One thing that's interesting is Dr. Sue, he did some research for the ICA and ACA, and he says they damage mice's sciatic nerve, and they track the Wallerian regeneration of the nerve, and he says it takes approximately 97 days for nerves to heal. So when the patient comes in with pain on any peripheral nerve, down the arm, down the leg, then in my opinion you should put that patient under care for 90 days or 3 months and make sure they're going to give you enough time for the nerve to heal. This is Ken Knox. He is an orthopedic surgeon. They have a whole new branch of medicine that is called physiatrists. And the physiatrists do not do surgery. As a matter of fact, he says here that that surgery, he says surgery is the last thing you should do. He says when you remove disc, lamina, or part of the vertebrae, you are removing supportive structures. And he says all conservative treatment should be performed first. So when they go in, start putting bones and clips and things in the spine. We'll show you some, but he says the surgery should be the last ditch procedure. This is a patient that was in the office like yesterday,